Starting.
Good afternoon, dear viewers, and welcome back to another session of Facebook Live with Your Fertility Center. So sorry for the slight delay because of some technical issues. But anyway, we're back on live, and thank you so much for joining us. My name is Emma. I'm from Get Dog, and together with me today is Dr. Agilan. So,
Hello.
hi, Doctor.
Hello,
Thank you so
hi.
much.
Hi,
Yeah.
Emma.
Hi. Yeah, great. So maybe you could just briefly introduce yourself a little bit.
Okay, I'm Dr. Agilan. I'm one of the fertility consultants here at Your Fertility Center. I care for both male and female infertility. Plus, I'm also trained to do a laparoscopic surgery to get a couple pregnant.
Yeah, I see. Okay.
Yeah,
great.
briefly. Yeah.
I see. Right. So, just a friendly reminder to our viewers that we are going to select 3 lucky viewers to win a free IVF consultation with Dr. Agilan. So, how do you entitle this? All you have to do is pop in your questions in the comment box below. We will randomly choose 3 viewers to entitle a free IVF consultation with Dr. Agilan. So please do pop your questions in the comment box below. Okay, great. So for today, our topic today would be step-by-step guide on your fertility test journey. When to do the right test at the right time to get pregnant. Yeah. So, Doctor, maybe you can give us a basic outlook of what the basic fertility test journey is like, and you know what couples are to expect.
Okay. Well, okay. So, when it comes to a fertility test for couples, all right, you can in fact do from A to Z. That's one way to look at it. But of course, I believe sometimes not everybody need all the tests. If you're more focused and then do tests which is necessary for that couple depending on their situation, I feel the time is shorter to reach where we want to go. All right. For example, somebody who's just trying for a year, no test done at all, for them probably it's worthwhile, you know, they start from A to Z and find out what is the reason. But however, for those who knows that they have an issue with fertility, they know they have factors. For example, they have endometriosis, they know they have previous surgeries to the fallopian tube, for example. So there's, for those couples, there is no need we do all the tests from A to Z, just that we can zoom in and do what is necessary. So overall, the fertility test journey may be different for different couple.
I see.
Yeah.
Okay, so in this advice, it would be best to kind of come in and do a bit of consultation.
Correct.
Patient's background to narrow down.
Correct. So from the initial interview with the couples, then we doctors be able to narrow it down and say which is the most appropriate test and in which sequence you're going to do the test.
Of course,
yeah.
Of course. I guess that would be the most efficient way as well. Cost saving too.
Yes, it is.
Great. Okay, so what do couples have to prepare themselves before undergoing any tests in that sense? Yeah.
Yeah, interesting question. They only need to be prepared mentally.
Mentally.
Yeah, they need to be prepared mentally that they have started a treatment and then they're going to go in. First step is they are trying to take the first step to come to see the doctor to start the treatment. For some, actually, that's not easy. Yeah. So that is the first thing. So mental preparation. Once they know that they are ready to move on and then start the treatments, the doctor will actually guide them on what to do. All right. So I would say that the most important preparation is just mental preparation. Yeah. And of course, their time. Time. We are all very busy.
Right.
Actually, we are busy. Everybody likes Saturday clinics. If you have a Sunday clinic, I'm sure the Sunday clinic will be full. Yeah, but unfortunately, some of the tests are done with their period.
Okay.
So
they fall on the weekdays.
We call on most of the time it's weekdays.
Oh,
yeah.
Okay. Great. So normally, if that's the case, do they spend like the whole day in the clinic?
Well, now that depends on what we're going to do. Usually, like for my patients, I'll try to minimize their time in the clinic. So usually some of them have already communicated with me, let's say via email usually, and then I will know some basic history about what is their situation. I will normally guide them and say, okay, you come in during this time and this is what we expect to do, so they know they are prepared. They know how long time they need. Of course, sometimes they need a bit longer time in the clinic, especially those who are waiting for the sperm test report. So they produce sperm, give, and then wait for the report. I see them. Let's say if they can allocate about 3 hours or so, 2 to 3 hours, depending on what we're going to do.
I see.
Not the whole day.
I see. That's good. Okay, great. So during the test, what are we actually looking out for both male and female?
Okay. Right. Let me briefly tell you, okay. As I said, the test is actually what we're going to do for the couple differs from couple to couple.
Of course.
Now, briefly, if you look at it overall, let's divide into male and female.
Sure.
Okay, the first thing that I always like to do is a sperm test first.
Okay.
Yeah, I know everybody thinks that the test should be focused more on the female,
Yeah.
but I will say 50% of the reason is due to male.
Oh.
And the easiest test to do is actually a sperm test. So I will say we do that first. Okay? So for a male, actually it's a sperm. That's the basic test.
Right.
Depending on the sperm test, then I will decide whether they need a further test for the male. For example, whether they need further blood tests, especially for those who have sperm quality or sperm count issue, or those men with no sperm. Then I need to do further examination. Plus, they may need further blood tests. Sometimes they need an ultrasound of the testicles to look for certain things, and then we move on from there. Yeah, that's for male. Yeah. So as I said, start with the sperm test, which is the easiest. Then we'll focus on the female. Now, just like a sperm test for male, which tells us where is his fertility. For a woman, it's actually her egg count. We start with the egg count. She can be very young, but sometimes due to endometriosis. Yeah, I like to use the example endometriosis because a lot of women with fertility issues, they do have endometriosis. Okay, she can be 30 years old or 31 or 32, where I expect a good egg number, right? But sometimes when you count the eggs, she has less egg numbers. That means her fertility is as though she's already like well beyond 35, 36 or 38. So that means we are rushing against time to get her pregnant. So advice to that couple will differ. So that's the first test for the woman, egg count. How do we do the egg count? Okay, simplest thing is an ultrasound scan during their period.
During the period.
Best time is during their period to count her eggs. Alright, sometimes if the egg numbers doesn't fit with their age, then we can move on to do a blood test. Okay, a blood test called AMH. Right, AMH is known as anti-Mullerian hormone. Okay, this is the hormone that are produced by her resting eggs. Okay, by getting the value, we're able to predict for that month if she need to go through an IVF, for example, what are the egg numbers that we can get from her. That determines her success rate for the treatment plus her fertility potential. Okay, that's the egg count. Then we look at the uterus, because uterus is the incubator for the baby.
Of course.
Right? Yes, correct. Either they're going to get pregnant with naturally, they're going to get pregnant with a simple treatment such as an IUI, or they're going to go through an IVF where we are placing embryo into the uterus. We need to check whether the uterus lining is normal. Okay, this is also done by an ultrasound scan. Right? Typically, if there is no issues with the initial ultrasound scan of the uterus lining, she wouldn't need any other further assessment. Okay, we'll probably talk about a bit later about what other further assessments are. Yeah, so that's the second thing for her. Of course, the third test is a tube test. Okay, woman, correct, fallopian tube. Woman got 2 fallopian tube. We go by her history. A woman who has no previous surgeries, no previous, let's say, pelvic infections, so we can reasonably assume that at least one of your tubes should be open. But sometimes between 5 to 10% of women, even though their history is clear, that means she don't have any risk factors that can block her tubes, but they can have blocked tube. So that's the next thing. Typically, I'll do the tube test after we check the husband's sperm. If the sperm is normal, then we're going to look for the tube. Is there any issues with that? They need to do a test called hysterosalpingogram, okay, known as HSG. This test is not done in the clinic here because you need an X-ray for that. Okay, it is done in a hospital in an X-ray department where a dye is injected into the uterus, and then if the dye flows nicely through the tube, X-ray is taken, and we know whether the tubes are open or not. So in a nutshell, these are the tests that we go through: sperm test, egg count, uterus health, and also the tube test.
I see. So previously you mentioned women, your favorite example, the endometriosis.
Yeah. Okay.
Maybe you could just give what this is.
Okay. Well, endometriosis is a condition where it actually can reduce a woman's egg number. All right. The theory so far that we know how it happens is the period blood that flows vaginally out, some of it backflow through the tube and implanted outside on the ovary or in the pelvic cavity. So what happens is every month when she bleeds, these same cells is implanted outside the uterus or on the ovary, they do bleed. They behave exactly like a period flow. So what happens is they bleed then the blood accumulates and accumulates, they can form a cyst on the ovary. This is what we call a chocolate cyst.
Right.
Now this type of cyst actually can reduce the number and also the quality of the egg. Thus it reduces the fertility potential for the woman. Yeah.
Okay, so how, is there any symptoms of this chocolate cyst?
Well, in many they may not have any symptom,
No.
but the typical symptom that we look for is a period pain.
Period pain.
Yeah.
Okay.
Sometimes they do have, a lot of women do have period pain, but however period pain doesn't correlate with severity of the endometriosis. Some of them, they have really terrible period pain. They have to go through a laparoscopy for the endometriosis, but once the laparoscopy is done, in fact the disease severity is mild. Some women, they don't have much of a symptom. They go through a laparoscopy, for example, they have a cyst that need to be removed. Once the laparoscopy is done, then I'll see that they have, the severity is quite high grade actually.
I see. Okay, so it's not really determined by your cramps.
Yeah.
To really see how severe the situation is,
you need to do a laparoscopy, but not everyone need it. But however, if there's a reason, for example, cysts we need to be removed, then of course they have to go through a laparoscopy surgery.
I see. Interesting. Okay, great. So the next question would be, what kind of tests do male and female need, as you mentioned already?
Yeah, that's a briefly initial test. Probably is the right term. Maybe tell you what are the additional tests they may need.
Additional tests.
Okay.
Correct.
Now, for a woman, additional tests that we're talking about are, number one, a hysteroscopy. Now, hysteroscopy is when we place a telescope into the uterus and have a look directly at the uterus lining. Now, sometimes by an ultrasound scan, we notice or we suspect that the woman may have an issue with the uterus lining. Very common issue will be a polyp. We call it a polyp. Now, basically, you see a pimple on your face, right? Basically, a polyp grows from the uterus lining just like a pimple. It's not dangerous at all, but if the polyp is big, it affects implantation of the embryo. That means you form the embryo, but embryo doesn't implant, doesn't stick, she's not going to get pregnant. So in those situations, she needs a hysteroscopy where we put a telescope in the uterus, have a look at the polyp, we just easily cut out the polyp. Okay, that's a hysteroscopy. Some women, they have a very thin uterus lining. That's why when you do the initial test for them, right, we will notice that the lining is very thin. Then we suspect, is there any issue with the uterus lining? In those situations, they may need a hysteroscopy to see whether there's any other problem in the uterus, for example, in additions. Some women may have a miscarriage in the past. They may need to do a DNC, for example, clear the pregnancy. During the healing process, sometimes the uterus lining, they get stuck each other during the healing process. That prevents the uterus lining from thicken up. So we can do an hysteroscopy and easily treat the condition. All right? So that's first thing, hysteroscopy. Some women may need another additional test, laparoscopy. I think we spoke about it just now, right? Now, why they need a laparoscopy? For example, during an ultrasound scan, we may suspect that she has a cyst. We may suspect that she may have a swollen fallopian tube. We could be blocked. In this situation, I won't tell the patient, go ahead and do the X-ray HSG test. She may do better if she goes through for what you call do a laparoscopy test, because during the same setting we can confirm whether she got a blocked tube. If the tubes are blocked and swollen, it can be removed in the same setting. So laparoscopy is a test plus is a therapeutic what you call test. So these are two additions. Yes,
multi-purpose.
Correct. But not, as I said, not everybody needs it. Probably 10, 15 years ago, maybe a lot of them goes through laparoscopy. Okay, but in the last, I would say less than 10 years, laparoscopy has fallen into, I would say, second level investigation. It's not a first level, second level investigation. But for some, it might be the first level investigation.
I guess it depends from the patient's history side.
Patient history and what do we suspect. That's why it's very important before they go through an A to Z test to have a chat with the doctor and decide which sequence they need to do the test.
I see. Okay, so we covered the female additional test. What about the male after the semen test?
All right. So let's say if a man have done a semen test and then he comes back, classic example, we see no sperm in it, called azoospermia. Okay, they have the semen, but there's no sperm in it. Now, in this situation, they need to do. Typically, I will examine them, looking at the size of the testicle. I'll ask further history to try to determine what could have caused that. Either it's a blockage in the pathway where the sperm is not being ejaculated out, or there is have purely production problem. okay, where the sperms are not being produced or the production is very minimal. Okay, to help with the diagnosis, that's when they need the additional tests, which are the blood tests. We check their hormones and to try to come up with a diagnosis. Sometimes some of them we need genetic tests.
Genetic test.
Yeah.
Okay, so this could be a genetic disorder.
Can, yeah, but it's very a small proportion of men who do not produce sperm and have this issue. So we test genetics and see whether what are the likelihood we can get sperm out of this man.
Right.
Okay, most of them with no sperm. Sometimes, most of the time I do give them some medication, try to make them to produce sperm.
Right.
Some succeed, some don't. The one who don't succeed, they need a small surgery to the testicle. When you mentioned the word surgery, everybody got scared. But it's not a big, it's a small procedure.
Right.
Probably I shouldn't say surgery. Yeah, small procedure where it's a daycare procedure, probably about half an hour, where we try to get sperm directly from the testicles.
I see.
Why I mentioned, yeah, because probably they're not going to have sperm. They may have sperm in the testicle, but just not enough to be ejaculated out. That's why in these men sometimes we do a genetic testing, because certain conditions we know, even though we go do the surgical procedure, we may not find sperm. So we can tell them in advance.
I see.
Yeah. Okay.
Anything?
Well, probably this. Well, other than that, it's an ultrasound. Sometimes if you suspect something from the examination of testicle, for example, most commonly we do it because we want to rule out cancers. Yeah, if the examination doesn't suspicion, then probably they won't need that. Yeah.
Okay, great. Now, how do you test for? You mentioned earlier there may be a hormone imbalance, and you give a prescription. So, aside from prescription, is there any other way to test hormone imbalance for male and female?
All right. Yeah. Well, this hormone imbalance word, right, is I believe it comes from a woman who has a polycystic ovarian syndrome or PCOS. Yeah. Traditionally, we used to test their hormones, and of course, we find that hormone imbalance that we are talking about. But in majority who do not have PCOS, hormone imbalance actually doesn't change what is their next cause.
I see.
Yeah, still up to date. This is 2018. We still do hormone tests for them because sometimes the hormone tests are done to check the ovarian reserve. Okay. Earlier I mentioned about the test called AMH, right? Of course, the more traditional test before the AMH is what we used to do, the hormone test called FSH. Okay. That also tells us what are the egg numbers that the woman may have, right? Higher the value, the lower the egg number that she has.
I see.
Okay. So these are the hormone thing. Other than that, I won't be so concerned about hormone imbalance unless that we suspect something through the initial interview.
Right.
If let's say, for example, again I bring the example of PCOS. If she has a PCOS, we may check her insulin level.
I see.
All right, to try to control the level so that she can have a regular ovulation. She can have a better quality eggs, and that also improves the chances to get pregnant naturally. Okay, or we suspect other medical condition, for example, high prolactin levels, and that. So then we check the particular hormones.
I see.
They don't need A to Z hormone levels,
Correct.
right? Even nowadays, thyroid hormones are not a first line. That we used to check it as a first line, but not anymore. If you don't suspect a thyroid issue from the history, then you don't have to go through the test.
I see.
Yeah.
So, doctor, earlier you mentioned insulin levels would hinder ovulation.
Yeah.
So how is the connection there?
Okay.
Insulin and ovulation.
All right. In a woman with a PCOS, what is PCOS? A woman has many eggs. She's born with a lot of eggs in her ovaries. Yeah. So a lot of eggs means good, right?
Okay. Yes.
But it's not so good for those women because when they have a condition called PCOS, the body has a very high resistance level to make the eggs to grow. Now, in a woman with, let's say, a 30 days period cycle, she has period every month, right? Eggs takes about 2 weeks to grow, and then it ovulates.
Right.
And the woman with PCOS, when the resistance is very high, she may take 1 month, 6 weeks, 2, 3, 4 months for the eggs to grow.
Oh wow. Okay.
Right, that's why women with PCOS sometimes they have period every 3 months, 4 months. Some of them they don't see their period at all unless induced with the hormones.
I see.
Okay. Now, insulin level in PCOS, especially those who are overweight or obese, insulin levels are high, and it has been shown to increase their resistance level. By controlling the insulin level, actually we reduce the resistance level for the eggs to grow. So they can make them to ovulate regularly. Unfortunately, to reduce the level, they need to take something called metformin, which is a diabetic pill. They are not diabetic, but they need to use that pill to reduce the insulin level.
I guess. Okay. Is this orally taken?
Yeah, it's orally taken. That's the first line, we do that. But some of them, even though despite a normal insulin level, despite they are working very hard to reduce their weight, that will be the first advice we will give them. Exercise and reduce your weight. They've done all possible, but still the eggs takes a very long time to grow. Now in those women, they need a second line treatment, which is a laparoscopy. And then we do something called ovarian drilling. We find the ovaries have many eggs, we put in a few holes in it. It's a very simple procedure, and that has been also shown to reduce their resistance level, and then some of them do start ovulating regularly.
So does this affect men as well, insulin and men?
Typically we don't check for insulin unless, typically no. No.
Okay, it's more for the women.
More for the woman, especially for PCOS.
I see. Okay, great. Thank you. So now the next question will be, is it possible to get tested in a general clinic or in my family clinic rather than in a fertility specialist?
Right.
Yeah.
So the general answer, yes, they can check. But the thing is, the doctor who are, let's look, general doctors, their knowledge is very broad. But the thing is, depends how well they know or how well versed are they with the fertility assessments. They can do the basic tests. They can do the sperm test. Sometimes they go and check their blood, check for the hormones. And if the general doctor is very well versed with the vaginal scan, because you can do an abdominal scan, but sometimes it's not easy to count the egg numbers by abdominal scan.
I see.
Typically we count the egg numbers by doing a vaginal scan. So if the general doctor is quite well versed with doing vaginal scan, they can count the egg numbers. They can do all these tests can be done in the general practice. But majority of the couples, however, ended up in a specialized clinic because sometimes we are very focused in the treatment that we do. But many of them do come into the clinics. They have done their initial tests with the general doctors. There's nothing wrong with that.
Just carry forward.
Just carry forward, or sometimes the tests which are not there, and then we just add on to it, or sometimes we repeat the test if we want to confirm certain certain facts.
I see. Okay, great. So if one of my spouse, either one of spouse has diabetes, would that actually affect their fertility?
Well, diabetes affects both male and female.
Right.
So general thing is, as long as a diabetic is well controlled, they should be fine. Now for a woman, if they have diabetes, it affects their egg. As long as well controlled, they should be okay. For a man, if the diabetes are not controlled, it can actually affect their nerve. And most of the time they can end up with erection problems.
So not so much on the sperm count.
Sperm count also can, but as long as it's well controlled, they should be fine.
I see. Okay, great. Now, earlier on we covered this already. Is infertility a genetic disorder?
Well, if you let's see whether I can add on some points to it. Genetic, yes, for a male. Yes, if they have an issue with their Y chromosome. Male is determined by X and Y. X and Y is for male, and then X and X is for female. Now, there are certain conditions where the Y chromosome will have a defect, so they don't produce sperm, or they produce sperm but in a very minimal quantity. That's when they need the surgery. And there are also other genetic conditions not related to sex genes, which also can lead to azoospermia, where they don't produce enough sperm. Now for a female, generally we don't see so much, but there are some conditions, for example Turner syndrome, where their lack of sex hormone, their sex gene in it, woman has 2 eggs, but sometimes they only have 1. So in those, however, these conditions are sometimes picked up very early, because those women, they have a certain physical characteristics where it could be picked up when they are younger. And then those women typically no periods, and then their growth are affected, and also and they don't produce eggs. Now, I remember that about probably 8-10 years ago, when I was still as a registrar, we have had a case where the female, she's well into her late 20s. Late 20s. They are trying to have a baby. They couldn't for about 2 years. Then they come and did a check, and then we checked the woman. We could not find her uterus and also her ovary. Couldn't find it.
Oh, interesting.
All right, very interesting. Couldn't find it. And then we did a genetic test for her. She turned out to be genetically male. They are a condition where they are genetically male but physically they are female. So she has a vagina, but there is no uterus, there is no ovaries.
So
these are very rare conditions.
So she doesn't have a period either?
No, she don't. Yeah, she never had a period. But physically she looked like a female. Yeah.
Okay, I see. So that means because she doesn't have a uterus, she can not conceive.
Yes, unfortunately, yes. Yeah, but these are all rare conditions. Majority are not genetically linked.
This is just one of the examples.
Yes, endometriosis are not genetically linked. Like, well, we have not found a good, strong link between genetic and the endometriosis, even though it tend to run in families. Same as polycystic ovarian syndrome, PCOS, it tend to run in family, but we don't have a strong link with the genetics yet. Yeah.
Okay, I see. That's cool. So in terms of duration, how long does a couple have to keep trying until it's there's a deadline or a cut-off date or year duration to say that, okay, I think I have to go and see a specialist?
Okay, this is the golden question everybody asks, right? How long should I wait? If you read the literature, typically we say 1 year.
1 year?
Yeah, typically the golden word is 1 year, but 1 year is depending on their own situation. For example, if you're a very young couple, less than 30 years old, they have no known factors which can contribute to infertility, well, they can try regular periods, no health issues, well, they can try for a year and see. Because if they try for a year, 8 out of 10 couples will get pregnant. If they try for another year, another additional one of them will get pregnant. So overall pregnancy rate about 9 out of 10. Now, if the couples are older, they are more than 35 years old, they have factors which lead to infertility. Classic one, they know they have endometriosis, they have previous surgeries to remove endometriotic cysts, they know maybe they have polycystic ovarian syndrome, PCOS, or they have certain sexual disorders. Yeah, those couples can't wait very long. I would say that they try for a 6 months. If they come in for an assessment so that we can pick up the issue earlier than later.
I see.
Yeah, so the 1 year thing is not for everyone.
I see. So it depends. So the longer they wait, actually, it's not really a good thing to wait too long.
Yes, not too long.
I see.
Well, nowadays sometimes the people tend to overdo it. There are younger couples who are coming and seeing me for a test, but they've only been trying for the last 2 months.
Oh, I see.
But well, I can't say they're wrong because they read a lot. People are worried whether they really have an issue. So those couple coming in early to check so that they have a peace of mind. Okay, I can keep trying for the next 7 or 8 months, you see, which is also not wrong. But I'm not telling everybody should do it, but goes by your own situation.
I see. Okay, cool. No problem. So apparently we have some questions here. It says here, I'm 31 years old, 3 cycles of Clomid failed. A count was 1 each cycle, changed to letrozole, and 1 egg only, but I still did IUI. Any higher chance to conceive?
Right, she's 31 years old. I'm assuming her egg count is normal. Of course, when she takes some medications, we try to make between 1 to 2 eggs. So maybe it's okay for her to have 2 growing eggs with Clomid or even with letrozole. Now, if she do an IUI, the chances to get pregnant is about 3 times higher. Okay. Generally, when everybody is trying to get pregnant, a young couple trying to get pregnant, just chances are somewhere between 3 to 5% every time they try. IUI gives about between 10 to 15% chance to get pregnant. Percentage-wise, it'll appear low, but if you compare between 3 and 10, it's about 3 times higher.
Correct.
Right? So I think she has done the right thing as long as the sperm is okay. And if you've done IUI once and things are not happening, she should also check her tubes. Check the tube, making sure that your tubes are okay. Right.
I see. So how long does she have to try IUI first and then decide to check on fallopian tubes?
In fact, there is no limit how many times you can do an IUI. If you, let's say if you're in the UK, they say that you can go up to 5 or 6 times an IUI. Because if you've done about 5 to 6 IUIs, about 40% or close to 50% of those couples with no major fertility issues will get pregnant. The remainder 50% need an IVF. So that model fits well in UK because your IVFs are subsidized. But it doesn't fit here in Malaysia. In our country, every single treatment you do is out of your own pocket money. If I say you go ahead, do 5 IUI, end of the 5th IUI, if she's still not pregnant, if you look at the cost, she'd have probably spent equivalent to an IVF, right?
Yeah.
But she will never know. Sometimes the doctors will never able to tell. I would say typically for my patient, I will say you can try. If no major issues, you can try up to about 3 times.
Okay.
If things are not happening, probably you should think of probably moving on to an IVF. Because IUI, what's happening is we're just injecting the good sperms into the uterus. We can't see anything else after that. We don't know the eggs are normal. We don't know whether the sperm actually met the egg, whether there is any fertilization, or whether the embryos are normal. All that we can see in an IVF under the microscope.
I see. Okay, great. So I hope that answers your question. So the second question here is, can a couple undergo IVF more than once? And is there a limitation to IVF treatments?
Right. The real limitation to IVF treatment will be a woman's age, I would say.
Age,
and also the cost. And also the cost. Now, the woman can go through more than one IVF. Sometimes those women with less eggs, they tend sometimes do more cycles to try to get more eggs and more embryos. Because the principle in an IVF is we typically try to make more eggs. That because not all the eggs are normal. Not all normal eggs are going to give rise to a normal embryo, which is genetically normal embryos. That's why we start with more eggs. For typically it's about 10 eggs. Then she may end up with about 4 embryos. Out of the 4, maybe not all normal, right? If she has 1 or 2 normal embryos, that's a baby, right? So those women who start with less eggs, they may need more than one cycle. Sometimes the woman may have an issue with the egg quality. She can be young. She may have endometriosis, which affects the quality. She may have more eggs to start with one IVF, but she didn't have enough embryo. She may end up with 1 or 2. Maybe she didn't get pregnant, then she has to restart the whole process again. And some women do batching. Embryo batching means they know that every month they can probably make only 1 egg and 1 embryo. So they keep going 2, 3, sometimes even 4 egg collection, meaning IVF. So that to find that one normal embryo which gives her the baby.
To do the implantation.
Correct. Yes. Of course, our aim is always people to get pregnant out of one IVF.
Of course. That would be best. So is there an age for, like earlier on was age and also cost. So what is the age for women to stop IVF?
Well, theoretically speaking, she can stop once she's menopausal, which is you're talking about 50, right? But of course, the ethical issues will come in. What if she's 49? What if she's 48? As long as she can produce eggs, she can still try an IUI, but the chances to have a live baby is probably in the range of 1%.
Oh, really?
Very low. Because at that age, let's say she's over 45, the chances to find the normal egg are very slim. That's why she may need more cycles. And if you find the normal egg, then of course usually the uterus have no issues. Uterus can carry the pregnancy. The bigger issue is to find the normal embryo.
I see. Okay, great. So another question here is, I have PCOS. My insulin level is high. Does this mean I have diabetes?
No. Insulin high is because of the PCOS. Yes, if your insulins are high and you have a PCOS, it means there are higher chances for you to develop diabetes either in pregnancy or earlier in life. So usually the woman with PCOS, we advise them, even though she's younger, to check for diabetes every year, at least once a year she will check. It doesn't mean you have a diabetes. Most of them, when they check the insulin, if they check their fasting blood sugar will be normal, but insulin is high in PCOS. No, so the answer to that question is no, you are not diabetic unless your fasting sugar level is high.
I see. So advice here is to actually go and get tested regularly to really
at least once a year or 2 years once, depending on their age.
I see. Okay, great. So I guess there is no more questions. So this is pretty much the end of our Facebook Live today. Again, thank you so much, Doctor, for sharing your knowledge, your time. It was very informative. And of course, thank you, viewers, for inputting all your questions in. We will definitely choose the 3 lucky viewers for free IVF consultation with Dr. Agilan. Now, a friendly reminder as well, there will be actually a free forum with Dr. Agilan about fertility treatments, when to do it, and all sorts of things. All sorts of details will be put into the KL Fertility Facebook page, so do check that out. That's on the 7th of April. Doctor, anything else you would like to add before we close?
Well, maybe I just would like to give an advice to the couples. When the couples who come to our clinic or those who come to our forum and then they start asking questions, sometimes I realize that, of course, everybody is at a different stage of their fertility journey, right? Some, I realized that they took a very long time to even take the first step to get themselves checked. Sometimes it's not easy to find the time, or sometimes sometimes husband and wife not in agreement when to start this whole treatment, right? I would say that first of all, for those who are trying to get pregnant and have not succeeded yet, get the right information. Right, get it from the right source so that you are equipped with knowledge. Knowledge is power. When they have enough knowledge, they know whether they're doing the correct thing, how long they can wait, and what the next step will be. Yeah, right. That's what I would like to say to them. Yeah.
Nice. Okay. Thank you.
Okay.
So be mentally prepared if you are to undergo this sort of journey. Of course, there are many helps here in KL Fertility Center. So we do hope that you, if you have any other questions, please do come along with the forum. So yes, that is all for today. Thank you so much, everyone. And
Okay.
we'll
Thank
see
you.
next
Thank you
time.
for watching.
Great.
Yeah.
Thank you.